It's a call that's telling me I'm here to serve. It's a need to make a difference in the world. 24 hours, day or night, these healing hands will make it right. Looking in their eyes, I know that I'm changing lives, changing lives, changing lives for the better, changing lives.
Hi again, everyone. I'm Candace Kruger along with Jim Knox, and we're back again with another edition of the Best Docs Network, featuring some of the best doctors in all of the Dallas and Fort Worth area that are helping to change people's lives.
Right you are, Candace. Over the next 30 minutes, you're going to see some unbelievable, inspirational stories about doctors helping change people's lives. Like our first doctor, it's world-renowned dermatopathologist, Dr. Clay Cockerell.
A number of things have sort of developed in dermatology over the last year and a half that have been very exciting that relate to what we do here at our laboratory. For malignant melanoma, which we diagnose many of those here each and every day, is that there are actually new drugs now that can treat melanoma, and that's something that we have not had at all for many, many years. One thing that we're doing is sending these tumors off to ensure that that marker is present. If it is, and the people are eligible for treatment of this very new, exciting drug. We make the diagnosis of the basal cell, and then once that's made, then if it's one of these terrible cancers that can't really be treated with surgery or even radiation, then they will be eligible for this new drug. We play a vital role here in making diagnoses of skin disease, but we interface a lot with dermatologists and non-dermatologists too, plastic surgeons, general surgeons, in recommending treatment options, not just medical treatment like drugs, but also surgical treatments and even other new, relatively new treatments, one of which is now radiation therapy that's being reintroduced back to dermatology. There's a fairly new device that's just recently been developed that's a small X-ray device that dermatologists can use in their own office and actually treat skin cancers. Years ago, that used to be the #1 way that skin cancers were treated. Now most of them are treated with surgery, but there are some patients in select cases that are good candidates for radiation. And we can look under the microscope and tell the doctor whether that cancer is going to be a candidate for radiation if they're not really a good surgical candidate. Labs like this one play a vital role in determining the diagnosis of these types of cancers, not only melanoma, but basal cell carcinoma, many other things. And we're now interfacing with labs that do genetic testing, and then getting more personalized medicine where you get a diagnosis, you see what the cancer's genotype is, and then you can decide whether there can be a therapy that can be tailored to that individual person. So this is an exciting new development that we're going to see happening more and more in medicine.
I started having tingling in my legs and toes, and it progressed. I knew there was something very wrong. So I made an appointment with my family doctor. Said that he thought that I would most likely have to go to a neurologist. After going through a number of tests, I had a cervical MRI on July the 3rd, and they found a very large tumor in my spinal canal.
Spinal cord tumors, when they present, generally present with weakness or numbness, but the weakness and numbness will not go away with conservative measures in terms of medication, cortisone injections. It will continue to progress. Spinal cord symptoms typically go on the order of months instead of days to weeks. They tend to get worse as time goes on, and they do not get better with conservative treatment.
When I went to Dr. Cattorini, he brought up my MRI and also had a skeletal prop that he showed me exactly where the tumor was and how large it was. He also explained to me that because it was so large, there were certain parts in the canal that were going to, be very close, where he may have to radiate the tumor. He went through everything. what the surgery was going to be like, how long it would take approximately, recovery time.
Surgery for spinal cord tumors is considered microsurgery. The tumor is removed under 1,000 times magnification or underneath an operating microscope. Small instruments the size of toothpicks are used to remove the tumor and the size of the head of a pin. And so it's a very delicate procedure and one that requires skill and patience.
I'm 4 weeks out of the hospital and it's been an amazing recovery. Dr. Cattorini, removing this tumor from my spinal canal has given me back my quality of life. I just cannot thank him enough for what he has done for me. I feel the best I have felt in a very long time, and that is because of his skill and the surgery.
For more information on any of the amazing doctors you've seen on today's show, just visit our website. It's bestdocsnetwork.com. And now let's check in with our next best doctor. It's gynecologist Dr. Patrick Allen.
For me, it was more a matter of, we had our son, he was 5, and we were trying to find different options besides birth control. I was on birth control for a number of years and was not feeling very well from it, and so we wanted to find other options of permanent birth control because we had decided to just have one child.
The Essure is a way to do a permanent sterilization in an office setting, which is without having to use general anesthesia. When we do the procedure, we do a paracervical block, which is like a local anesthetic we put in the cervix to help the cervix when and you usually don't have to dilate, but when you put your scope through it, sometimes it causes some cramping.
The procedure is they go in and insert coils into your tubes, and over time, it was like a 3-month period of time, that your body just naturally produces a scar tissue.
Once we can see them, we just try to place the coils. There's a little tiny, they're very small. We place them into the tube and then we release them and we go to the other side and do the same thing. And then if it goes well, within 5 minutes you're done.
And then you'll go back in after that 3-month period and they shoot up a dye and they make sure, I mean, you can see it. I was able to watch it on the machines where, sure enough, it had worked.
Probably the biggest advantage is it's just not a lot of downtime. I mean, you don't have to put the patient to sleep. They don't have any issues with general anesthesia.
That's what sold me on it, that it was an in-office procedure. I wasn't going to have to be cut on. I wasn't going to have to go under any kind of anesthesia. I'm extremely happy with the results. To know that going forward, I don't have to any longer rely on birth control, remembering to take my birth control, or having the ill effects from it, that it's now a permanent thing, and my husband and I can enjoy each other and not have to worry about anything, that we get to enjoy our family of 3, and that's how it's going to be. And so it's been a great, worry-free experience.
Gynecomastia is a very important part of our practice that I enjoy doing. Gyneco means woman-like, and mastia means breast or chest, so it's a woman-like breast. On a man, that means not just necessarily obesity, but also the glandular tissue that comes along with it, which is the hard, fibrous area that you can actually feel under the nipple and the areola. We see many young men who get it with the onset of puberty, and then we see many men in their 20s, 30s, and 40s who have no antecedent cause for this. Gynecomastia surgery traditionally has not been a very satisfying operation for either the surgeon or the patient. And the reason why is 99% of surgeons are still doing the same technique that's been done for the last 80 years. They put the patient to sleep, they make a 3 o'clock to 9 o'clock incision around the areola, they start cutting out the tissue under direct vision, then it starts bleeding, they can't see very well, they may get a contour problem or a depression, and then ultimately they put drainage tubes in from the side to drain out the fluid. So about 9 years ago, I came up with a new idea. No scar at all on the chest, no drainage tube. We're able to remove the 2 components of gynecomastia, the fatty tissue and the glandular tissue, through an incision this long under each arm. And there are two instruments that allow us to do this: the use of ultrasonic liposuction, and we have a multi-jointed cutting device. We're able to cut out the rest of the glandular tissue with an instrument that goes through this incision all the way down to the nipple. After we've cut all it out and it's perfectly flat, the last thing we do before closing the incisions is to re-inject the entire field with a long-acting anesthetic called Marcaine. So when the patient gets up, we've already got the compressive garment on, they're pain-free. They're typically only in the recovery room 45 minutes to an hour, and that stays numb till the next day. They wear the compressive garment under their street clothes for 3 weeks, and they're done. We see them at 8 to 10 days post-op. We see them 6 weeks after that, 3 months after that, and they're delighted.
Don't forget, for more information on all the outstanding doctors you see on today's show, head to the website bestdocsnetwork.com. That's bestdocsnetwork.com.
Lots of information there. And now we're going to head to our next best doctor. It's Mohs Surgeon, Dr. Patrick Walsh.
Mohs surgery is a surgical technique for the removal of skin cancer that enables us to examine all of the surgical margins of the tissue that were removed so that we're sure that we've gotten all of the skin cancer.
The first time I had any problems was out in California. And I had some work done in here. But the doctor told me, he says it might come back, because they didn't have the Mohs system at that time. Then I had this one.
Mr. Waddy, you're presented with a recurrent squamous cell carcinoma involving the right posterior auricular area. The posterior auricular area is the area behind the ear and extends onto the anterior portion of the scalp and the upper portion of the neck. It also involved the posterior aspect of the right earlobe. During Mohs surgery, we were able to get a clear margin. I believe it took 3 stages of Mohs surgery before we had clear margins. The resulting wound was approximately 3.5 centimeters long by 2.5 centimeters wide. What we did was come up with an advancement flap that required removal of Burroughs triangles, small little triangles of tissue at the superior and inferior edge of the wound. We then undermined the tissue, advanced it to the edge of the posterior auricular sulcus, sutured that in place, and then used one of the Burroughs triangles that were excised as a skin graft for the defect on the posterior aspect of the right earlobe.
See, you had to do a little patch in there. See, the ears aren't the same. See, I lost part of my ear here. It's healing up a lot better than I thought.
He's now 4 months post-op. All of the sutured areas have healed very nicely. The skin graft took very nicely, and everything looks perfect.
These make you feel relaxed all the time. It really is nice.
Most of us have allergies, you know, itchy nose, runny nose, itchy eyes, sneezing. It's no fun. There's lots of good treatment for that. First of all, avoidance. If you know what you're allergic to, stay away from it. Secondly, you can get allergy shots. That's kind of after trying other things first, but you can be tested for what you're allergic to, and then you take shots for it, and it desensitizes you to those things. There's also great medications, many of them over the counter. Now, there's 2 classes of antihistamines. That's the main treatment for your allergies. The old-timey antihistamines that we use, the chlorpheniramine and brompheniramine, there's lots of brand names, but those are the generic names. They're great for allergies. However, they can cause drowsiness, and they therefore developed new allergy medicines. These are 3 over-the-counter medications, such as loratadine, which is a generic name, and 2 others. These are great in that they don't cause drowsiness. The problem is they're not quite as strong. So I think if you're going to be driving and carrying kids around in your car, I think it's best to use the non-drowsy ones. But if they don't work, you better use some of the old-timey stuff that works real well.
Well, Anna was about a little over 200 pounds. She had diabetes and high blood pressure.
I had sleep apnea, and I didn't like the way I looked. And I hated that when I would go to the doctors, they would write down obese. And I didn't think size 18 was obese, but medically, it was considered obese.
We talked about the different kinds of procedures that you can do for weight loss, and she wanted the lowest risk operation that you could possibly do, which is the band. And we spent some time discussing the fact that this is a restriction, and you have to be a very dedicated person in follow-up, that you have to carefully follow your intake, and after the few bites that you eat and then you feel full, that's when you need to stop. We all know that your weight is dependent upon how many calories you take in and how many calories you burn. And so if you can burn more calories, then you can lose weight. If you can take in fewer calories, you'll lose even more weight. And she's done very well with this.
I give myself a goal to reach. Once I reach that, then I try another exercise. So I did Zumba, and that was fun, which I would never do when I was fat. It's been an ongoing journey. It's been a positive one. I've enjoyed it every day because every day I see my scale go down. And it's nice to see those numbers go down instead of going up. Every year prior to lap band, my numbers went up.
She's lost down to about 130 pounds, and the benefit of losing that weight is now her diabetes is essentially resolved.
The sleep apnea is gone. I sleep much better at night. Now I'm a size 8, and I've even worn size 6s, and when I pick them up, I think, that is too tiny. And then when I walk by and see myself in the mirror, I have to walk back again and step out. Is that me? I hadn't seen myself skinny. Not since high school. You're hot. I like what I see.
I travel quite a bit for a living, and noticed in an airplane magazine that Dr. Lewis was advertising for cosmetic dentistry, and never gave it another thought until I tried to get my teeth fixed back where I live. And I found that I had to wear braces for quite a few years, and that wasn't a good alternative for me, so I did some research. I don't know if there's cosmetic dentists up there, I'm sure there are, but I just didn't investigate it. But I did investigate this one and thought, wow, this looks like a good as any, and if he's going to advertise in an airplane magazine, he must be pretty good.
So he sent me a lot of pictures and stuff before he came, and I knew I could help him out. And so he came in one night and got here late, and we stayed and took care of him, prepared his teeth, made him some temporaries that looked fabulous, let him go home, and then came in and we put them on, and he's just been really happy with them, and it made a big improvement on his smile.
I spoke with Christine quite a bit, more of a consultation type of format, because obviously I kind of skipped a couple of steps in the process because I live so far away. But just very helpful. Christine kind of explained the process, what was done, what's going to be done, how it works, I mean, and getting the quotes and the pricing and everything. So it was very consultative, very helpful.
We did prep veneers on him, but it was not extensive. I mean, just because you have to prep the tooth doesn't mean you have to take it down. A lot of people think, oh, you're gonna have to take my tooth down to a little nub or something like that. No, sometimes it's just a matter of a little smoothing that is very, very minimal.
I was getting pretty self-conscious of when I would laugh or smile of putting my hand over my face, because I was just, oh, that's funny, something like that. And what I found is it's somewhat liberating to the point where I find myself not doing that anymore, which is nice. I mean, actually, when I smile for a picture with my family and my kids, I actually smile instead of, kind of half smile it. And they're always making fun of me for that. So very happy with the results. The staff is very professional. They obviously know what they're doing, but the results are fantastic, really are.
It doesn't have to be a trip to the dungeon. It doesn't have to be uncomfortable. I would just say, come in and experience it, see for yourself. It really can be very pleasant.
We are here with one of the best doctors that specializes in the back and neck. He is a pain management specialist, a board-certified physician that treats problems with the back and neck. And some of your patients that come in, what are the most common symptoms?
Well, patients that come into my office often complain of neck pain that may or may not be associated with arm pain, numbness, or tingling, or shoulder pain, numbness, or tingling. They also might be complaining of thoracic or mid-back pain that may or not be associated with numbness, tingling, or pain radiating around to the ribs. Most commonly, they come in complaining of low back pain that may or may not be associated with leg pain, numbness, or tingling, or otherwise known as sciatica. What we find out is, upon evaluation of these patients, that this procedure addresses these conditions such as a herniated disc, a bulging disc, scar tissue that might be in the spine from trauma, or even patients that have already had a surgery on their back and or a fusion of their back that still can be treated with this minimally invasive procedure.
Dr. Williams is one of the only specialists in the world that does a minimally invasive procedure that can detect and treat neck and back problems. Explain this procedure.
What I do is I make a very small 2 to 3 millimeter incision in a natural opening above the patient's tailbone without damaging any bone. It also has a laser, a state-of-the-art laser, and a high-definition camera that I can drive up to the patient's, into the patient's spinal canal and examine the patient's spine for herniated disc, bulging disc, scar tissue, inflammation, and then treat that patient's pain or a condition right there.
All right, Dr. Williams, so I have the procedure on my back or neck. What about the recovery time? How long?
Well, I'm glad you asked that, Jim. Since it's such a minimally invasive procedure and an outpatient procedure also, I usually can have a patient back at their desk job or office job the next week after they have the procedure.
All right, there he is, Dr. Jason Williams, the go-to doctor when it comes to back and neck problems. All right, thank you, doctor.
Thank you so much, Jim.
Coronary artery stenting is a part of interventional cardiology that I absolutely love. It's been around for about 30 years now. Initially, the great giants of cardiology formed a cardiac stent, which is just a metal mesh that we place on a balloon catheter, place it into the coronary artery that's obstructed, open it up, leave the stent, and remove the balloon and the catheter. Easy procedure, but years ago it was quite difficult, and catheters were larger. There were a lot of bleeding problems, but now the catheters are quite small. The procedure is fast, done quickly and without much discomfort at all for the patient. If a patient presents with coronary artery blockage, they can go to the cardiac catheterization laboratory, have the coronary angiogram procedure done, and then if there's a blockage, we can place a stent right at the same time. Coronary stenting has protected many patients from going to cardiovascular surgery, has improved lifestyle, and many patients have gone without symptoms for many years because of coronary stenting. We thank the developers of coronary stenting, and we look forward to a future of great developments with regard to the coronary stent.
For years, I suffered with neck pain, shoulder pain, and probably the last 5 to 6 years it started radiating down both arms.
A lot of times people don't realize that their underlying problem is coming from pinching of the spinal cord in their neck.
I couldn't even do housework. I mean, vacuuming, anything like that would cause pain. I couldn't play with my grandkids. I used to get out and play basketball with them and play softball, and I couldn't do any of that.
Rhonda had a lot of arm pain. She had numbness and tingling that radiated from her upper arms, through her forearms, and down into her hands, in both hands. She had worsening function over a period of a few months, and she was even developing some weakness. So we had x-rays and MRI done that showed 2 herniated discs. There's 7 bones in the neck, and in between her 5th and 6th bone and the 6th and 7th bone, the discs there were herniating and pinching her spinal cord and also the nerves.
He told me that he could do a very minimally invasive surgery whenever I was ready. It would be a small incision in the front.
Typically, neck surgeries are very successful surgeries. The outcomes are very good, and people recover a lot faster. We have to go through less muscle and tissue in the neck, even though we do these minimally invasive in the back and the neck. Still, patients' recoveries are much quicker and better in the neck.
I was amazed at how much better I felt. I mean, as soon as I woke up from surgery and it was oriented, I was out of pain.
If you've had a doctor help change your life, we'd love to hear about it. Send us an email at info@bestdocsnetwork.com.
I am a referral specialist for 4 doctors, and what I do is I receive referrals from other doctors, and then the doctors, they see the patients, and if they tell me that they need to be referred to have a CT scan or an MRI, then we choose the facility, which I prefer preferred imaging, and then I send them an order for them to have either an MRI or CT scan.
Preferred imaging stands out in customer service excellence. I'm able to get our patients in same day, and the patients are happy. They get in, they get out.
I've heard that patients, when they come to the preferred imaging, they feel like they get first-class service and very nice people to work with, and as if they were going into, on a airplane flight, it's first class all the way through.
Because we get the results within 24 hours, we're able to get the patient back right away and the same week, and we can diagnose the patient via the MRI results, and we can therefore know how to treat the patient and go from there.
They're always nice on the phone, they're eager to help, and there's no miscommunication at any point at all. So it helps me when I'm able to call any facility that I can, and then they're there to help, and they're always nice, and it makes it easier for us.
Preferred Imaging has 14 imaging facilities around the Dallas-Fort Worth area, and they do have extended evening hours during the week, and they're also available on Saturday and Sundays. So it accommodates all of our patients' needs, whether they have to go after work, before work, on the weekends. They really make it easy for the patients. We send over an average of 10 to 15 a day. Our experience with Preferred Imaging it's amazing.
Well, that'll do it. That'll wrap up another edition of the Best Docs Network, featuring some of the best doctors in all of the Dallas and Fort Worth area that are helping to change people's lives.
The good news is, Candace, for more information on all the outstanding doctors you see on today's program, head to the website bestdocsnetwork.com. That's bestdocsnetwork.com.
And as always, if you have a question or comment for us, we'd sure love to hear from you. Send us an email at info@bestdocsnetwork.com.
So long, everyone. We will see you next week.